Good evening, everybody. First of all, thank you very much for being a speaker as well as for chairing the session. I think we will go by the clock. So if we can, so Mo is going to keep the time. He's going to introduce the speakers, and I'm going to introduce the chairs. And I've got a brief bio for everybody. So I think I have got. I think I've got all the bios. Yeah, that's fine.
Yeah.
Yeah. And whether to take questions in between or not will depend on the traffic of questions, actually. I think we have altogether more than 100 people. What is the total number now, Mo?
I think it was 160 registrations.
That's a huge number. So I think we have to be careful. I think we are probably better off taking one or two questions, perhaps from the chairs during the in between the presentations, and then so the chairs can sort of discuss a little bit, maybe two questions each, or one or two questions, maybe one question each for every chair, or one comment, or one sort of sharing knowledge, that kind of thing. And then towards the end, more perhaps we can go to the wider community and say that your questions will be answered. And if you moderate that bit of the thing, then it will work out, I think. Is that okay?
Yeah.
Because otherwise you can be swamped with questions and you may not finish. Yeah. Okay, I think so. What I have got here, just to make sure there is no confusion, I have got Shiraz first, then Andrew, followed by Susan. Yeah, is that okay?
Yeah.
So you are going to introduce the speakers, and I'm going to introduce you and Claire and Krishna, right?
Yes. You're going to introduce the chairs, Mr. Griffith, Ms. Donaghy, and Mr. Murthy.
Yeah, sure. So who's here? I think I can see you, and I can see Claire.
All of them.
Krishna here? Krishna is not here, is he? Yeah, no, he's not here. Okay,
I
think we should.
I'm here.
Oh, hello. How are you? Right. Okay, let's start then. Speakers first, followed by the chairs. Over to you, Mo.
All right. Hello. Welcome, everyone. Welcome to the first TUGS OG webinar. My name is Mohammed Abul Azaim, and I'm a ST4 surgical trainee in Royal London Hospital in London. And I'm co-leading the TUGS OG group with Mr. Deep Mukherjee. So I'm going to introduce the speakers for today. Our first speaker is Mr. Shiraz Marker. Shiraz is qualified from Cambridge University in 2007, and he's currently the Deputy Director of Surgical Interventional Trials Unit in Oxford, and he's the Upper GI Robotic Fellow at UMC Utrecht, Netherlands. He's finished 2 PhDs and has more than 260 peer-reviewed publications. And his primary research interest is in surveillance and survivorship following esophageal and gastric cancer treatment. Thank you, Shiraz, for being here with us today. Our second speaker is Mr. Andrew Davis. Mr. Davis is a consultant upper GI surgeon at Guy's and St. Thomas's Hospital in London. He's honorary reader at King's College London and the chief investigator of the PREEMPT trial, Prehabilitation in OG cancer patients. He's also the lead of the OGIS working group on prehabilitation, and he's a member of the Oncology Translational Research Collaboration and the National Cancer Research Institute subcommittees on the prehabilitation in OG surgery. Thank you, Mr. Davis, for being here with us today. And our final last speaker is Ms. Susan Gisberts. Ms. Gisberts has graduated from AMC University of Amsterdam, 2002, and she had her training at MCU Utrecht University, finished her PhD, and she's currently a consultant upper GI surgeon and the principal investigator at the Amsterdam UMC Utrecht. She has been proctoring minimally invasive esophagectomies and gastrectomies at different centers in Netherlands, and she is a member of multiple international communities, such as International Society for Diseases of the Esophagus and other communities internationally. Thank you, Ms. Gisberts, for joining us today in our first TUGS OG webinar. And I'm happy to co-lead this with Mr. Mukherjee. Mr. Mukherjee is a consultant, also OG cancer surgeon in Queen's Hospital in London, and he's our TUGS OG lead for this group. Over to you, Mr. Mukherjee.
Thank you, Mohammed. The purpose of TUGS is democratization of surgery so that everybody all over the place has same access to surgical knowledge and expertise. And that is the purpose of it. We believe in high quality. And so first of all, thank you for those who have joined in on virtually, because I know that some of you, the timing is not convenient, and we really appreciate it, because without you, this webinars are going to be meaningless. Do write your questions in the chat box, and we'll try to accommodate as much as we can. We have got 160 sort of participants, so we may not be able to answer all of them, but I'm sure that speakers and the chairs will respond to as much as you can, depending on the time. It is my great pleasure to say that as you saw the sort of illustrious speakers, the chairs for today are also experts by their own right. They're opinion makers, they're international authorities. Some of them are good friends, and they all have their own track record in high quality research, education, and good practice in surgery. So this is really special, actually. I mean, I'm overawed by the quality of speakers as well as chairs we have. First of all, we have got Mr. Ewan Griffiths. Ian, would you mind just lifting your hands so that they can recognize? Some of them can. Yeah. Your name should appear to everybody. So Ewan started something really original. He started the COLES study, which was the first sort of study of its kind, which told us what the real world looks like. He is from Birmingham, where I trained as an SHO, and he worked there as a consultant for more than 10 years, and he's well known in upper GI circles. He does cancer resections, esophageal reconstruction, and complex benign disease. And I think, you know, the recent West Midlands esophagogastric anastomotic audit was also led by him and was presented in OGIS. Some of you may have heard. So thank you, Ian, for giving up your time. And I really want to thank you at this stage that this is all being done free of cost. So, you know, these are very busy people with extremely busy surgical practice and academic work, and they're giving their time for free. And if I forget afterwards, I just want to say that I cannot thank you enough for that. The next person is Claire. Claire has a huge research portfolio. Some of our review articles are widely read for people like me who do not always understand sort of complex statistics and stuff like that. But she makes it easier for a lot of us, and she has got also a lot of original research. She graduated from Trinity College in Dublin and is a consultant surgeon specializing in upper GI surgery at St. James Hospital in Dublin. She has had 2 international fellowships in esophagogastric surgery, both in Newcastle upon Tyne in the UK and also in Oregon in US. She did her PhD in 2013, which was funded by Irish Cancer Society. She also has an interest in medical education and holds a master's in this area in the University of Dundee. She is the first author on 33 publications, co-author in 72 others, and has written 7 book chapters. And I think I certainly say that one of the things that in TUGS is very, very important for us is diversity. And for the lady surgeons who are going to join in, here you have got a fantastic role model, somebody who can inspire you. The next one is a good friend of mine, Krishnamurthy, who I have associated with over many years and is currently working together on some projects. Krishna is a senior lecturer and consultant upper GI surgeon at the Imperial. He is a real sort of enthusiast in prehab, started this work a long time ago and has done a lot to popularize it and make it a common sort of household name in upper GI surgery, if I may say. He's a senior lecturer and consultant upper GI surgeon in Imperial. His research interests are driven by his desire to improve patient safety and quality of care in surgery, which is something that is close to my heart. He co-developed a pre-pair publication program in Imperial College, which won BMJ Surgical Team and Patient Engagement Awards. He's also the co-founder of OncoHealth, which is a digital health startup, so he's an entrepreneur as well. This enables NHS to provide equitable access to prehabilitation to all cancer patients, something that we are piloting in my institution as well. So I think without much further ado, I thank you all wholeheartedly for doing this. Hope that you will come again. And over to you, Mo, to start with the preceding thing. And may I just request the participants to write the questions, and I'll stop this monologue and let speakers to get on with it. Thank you, everybody.
Great. Shall I go? Yeah. Can you all hear me okay?
Yep.
Yeah, perfect. Great. So first of all, I'd really like to thank Tugs for the honor and I think actually the genuine privilege to present today. I think it's a great initiative that we're doing here, and I'm really proud to be part of it, actually. So I'm going to talk to you about prehabilitation and really, is there an optimum regime? And I feel slightly a fraud in doing this because many of the things I'm going to talk about are things that Mr. Morphy taught me, actually, and we lived when I worked with him as a registrar for many years at Imperial. So I have no disclosures except for the fact that I always say this, but I'm a very poor registrar married to another female, another poor surgical registrar, and we really would love to have some disclosures at some point in life. But if anyone wants to buy me a bottle of wine, you're more than welcome to. So we published this paper this year, actually. It was a meta-analysis really looking at what's been done in the field of prehabilitation and really what the kind of weight of evidence is. And really what we were able to establish is that there's a few randomized control trials and a lot of cohort studies or non-randomized data. But when you pull it all together, it appears to be that the most important or most consistent outcome is that prehabilitation appears to reduce the incidence of postoperative pneumonia. And that is independent of the surgical approach. When we start talking about minimally invasive esophagectomy and things like this, it's really important to understand the important value of prehabilitation in driving down these pulmonary complications, which we're spending huge amounts of money in terms of looking at minimally invasive or robotic approaches. So when I think about prehabilitation, I think there are sort of three main aspects to it all in my mind. So the first is physical exercise. So we talk about aerobic training, resistance training, strengthening exercises, or specific muscle groups and inspiratory muscle training. And I'll talk a little bit about that right at the end with some science that we're touching on with one of my PhD students, along with specific training of core muscle groups. Now, the thing that's different with esophagectomy or gastrectomy, but I'll focus largely on esophagectomy, is that that the operation is completely different to our colorectal colleagues. So we really have to think about how we optimize physical exercise specific to our patients. And I'll touch on this in the latter part of the talk. So the other thing that we have to really think about is nutrition. Sorry, I put loads of pictures of my kids in. Some of them are a bit inappropriate, but I apologize. But anyway, nutrition is really, really important. So you have to think about robust dietitian assessment. Also, collection of food diaries is a really, really important thing. And there are lots of apps now, and in terms of online-based food diaries, which are becoming increasingly more used in a research setting, but I think will become more commonly used in clinical practice over the next few years. Also, it's not just important just in terms of the weight of the patient as we traditionally would look at it, but now we have to start to think about macronutrient and calorie assessment, and particularly whether or not high-calorie diets are good or bad things. In a prehabilitation setting, they may be good, but in a long-term prognosis from the cancer, they may actually be bad. And there's some data to suggest that. So we really have to think quite carefully about what type of nutrition we're giving our patients. And then we have to think about the psychology of patients. I don't know what my son was thinking on the far right of the picture, but anyway, there you go. But this is an aspect that I think is often neglected. The psychology of a patient is absolutely important. Mr. Morphy and I used to talk about this a lot, but my background is both my parents are psychiatrists. So I think it's really, really important and underestimated in how we prepare patients for surgery is their psychological well-being. It's commonly measured with things like hospital anxiety and depression score or URTC measurements. But in actual fact, I don't think these are great metrics for how a patient is doing from a psychological point of view. And Mr. Moore, Krishna used to always talk about regular touch points. And I think this is really, really important in terms of these patients is during their prehabilitation program, having regular touch points with the clinical team or the psychologist of the clinical team to make sure that they're progressing in terms of from a psychological point of view, as well as a physical point of view. So the core components of prehabilitation really fall into three main categories: physiotherapy, nutrition, and psychology. And I think the one thing that I really think, if you're going to take anything away from this talk, is that these three factors are all interlinked. They're not, one thing won't benefit. If you do one thing in isolation, it's unlikely to change the outcomes for your patient. So in actual fact, you have to take a multimodality approach and truly a multidisciplinary approach in terms of your designing a prehabilitation program, but also in terms of the implementation of it. So I'll give you some examples. So I'm only going to present to you randomized data. This is the best available data that we have on prehabilitation. So this trial was partly from Utrecht, but also from Leuven and Dublin, John Reynolds' group in Dublin. And essentially they did a randomized control trial on inspiratory muscle training. So they primarily focused on exercise. So they did flow resistance training, which is a relatively common method of intensity muscle, inspiratory muscle training, but they had no aspect of nutritional standardization, and they had no aspect of psychological standardization in their prehabilitation pathway. This is the largest trial ever conducted. So over 240 patients in each arm. And I think that's a really, really great achievement for them in a multi-center trial. Importantly, what this study showed was that it showed no significant improvement in post-operative pneumonia, death, length of hospital stay, ICU stay, or readmission. It was a negative trial. So I would argue that perhaps it was a negative trial because the trial only focused on one specific aspect. Now, it could be argued that that was what they really wanted to do, and that's totally fine, and I understand that. But the point that I'm trying to make is that it's a multimodality approach to prehabilitation, and that's something we really have to take away from this. So the next trial that I'd really like to talk about is from Lorenzo Ferri's group in McGill. And this trial was a more multimodality approach in terms of that they included home-based exercise 4 times a week, aerobic exercise, which is primarily around walking, jogging, or cycling based upon patients' underlying physical fitness, along with strengthening and resistance training. They had a nutritional aspect to their trial as well, which was tailored specific to the patient, involving dietetic assessments, supplements as required, and also logbooks in terms of recording of nutritional supplementation. And psychology was assessed and prescribed as needed. And what they showed within their trial, which is, I think, really important, is that they showed that there was relatively long-lasting effects in terms of physical fitness seen in the prehabilitation group compared to the control group. Now, it could be argued that, and I think this is an Achilles heel of a lot of the trials that are being conducted in prehabilitation, is that the external validity of the trial may be slightly lower than what we would hope, partly because of the fact that if you look at the number of patients assessed, it was over 200 patients, but the number of patients who were randomized was only 51. So less than a quarter of patients assessed were randomized within, or 68 were randomized within the trial, and only 51 made it to analysis. So I think that's the real Achilles heel of when we start to think about prehabilitation programs outside of a randomized controlled trial. How do we make them applicable to the average patient undergoing the average surgery? And this is, in my opinion, probably the best randomized controlled trial currently published. It comes from the group in Guildford, led by Sean Preston and Jav Sultan, who's now in Manchester. But essentially, this trial had a really good multimodality approach to it. It had supervised exercise 1 hour twice weekly for 15 preoperative weeks, involving cycling, resistance training, and flexibility training, nutritional support with specialized dietitians, and along with a really good psychological support with 6 sessions, along with social and support assessment, and also including some assessment of emotional management, which I think is really credit to the team actually who did this. Again, the trial only ended up including in their analysis 48 patients out of 153 analyzed. However, the thing that was really good about the trial is they showed not only an improvement in terms of the physical fitness of the patients, but also in terms of their long-term quality of life. And this led up to an improvement in quality of life over the control group up to 6 months after surgery. And I think that that's a true reflection of the multimodality approach that they used within their trial. And I'd just like to touch, just to sort of towards the end of the talk, to really talk about what is the measurable benefit from prehabilitation and how do we measure it? And I think this is really important as we start to think about research in this area. What is going to be the primary goal of our work here? Is it completion of neoadjuvant therapy? Is it actually reducing the postoperative complications, which is what we focused on traditionally? Or a shorter length of hospital stay, better health-related quality of life, or better long-term survivorship? Or perhaps, as Mr. Morthy used to always talk to me about, and I really agree with him, is that perhaps it's the opportunity to create a behavioral change in patients. And in actual fact, our patients have, long-term problems with exercise, long-term problems with behaviors, which can potentially be modified at that particular time they're given their cancer diagnosis. It's a teachable moment. And then the question is whether or not those effects will be long-lasting after you've given your prehabilitation course, which I think is perhaps the most interesting thing with rehabilitation, is whether or not we can provide long-lasting effects in patients' quality of life and behaviors. So I'm just going to touch on the utilization of technology with this aspect of survivorship. So this is a work that's currently being undertaken by one of my PhD students at Imperial. And we're really interested in basically how a patient breathes after a esophagectomy. So we do something called Vicon analysis, which is basically whereby we place lots of sensors onto a control patient in this setting, but also patients. And it's used by athletes, this technique, to look at their gait in terms of analyzing the way that they move. And what we end up doing is we create a 3D model of the rib cage, of a patient's rib cage. And from that, you're able to look at every sector of a patient's the way that they breathe. And each triangle here represents an area of the chest wall. So you can really break it down in a lot of detail. And from this, you can also map spirometry, so you can look at how patients breathe as well in a more traditional fashion. And interestingly, what you look at when you look at these volumetric changes in the chest wall is that this is a control patient, and we ask them to breathe 3 times in a very standard fashion. And you see a relatively consistent measurement in terms of the contribution of the abdomen and the contribution of the chest to the overall volume that's produced in terms of the way that you breathe. And you get a graph kind of like this, which is around 60% is produced from the chest and around 40% is produced from the abdomen. So we've gone on to look at this in more detail, looking at patients who survived upper GI resection. And these are patients who've had an open Ivor Lewis's resection at Imperial College. And the thing that I'm really interested in is looking at the chest wall, both in terms of the actual physical structure of the chest wall, but also dynamically how it moves. So these are 3D reconstructions of a patient who's had an open Ivor Lewis esophagectomy. And what I point out here, and this is consistent amongst most of the patients that we've studied, is there's a massive gap in the rib. In the rib space here. And when you think about the musculature around this and how this heals with a huge amount of scar tissue, and which will obviously impact the long-term function of these patients. So perhaps we have to think about, in the perioperative setting and the preoperative setting, how we can give patients specifically tailored breathing exercises to this aspect that may improve their long-term function. And this really highlights the point, which is this is a control patient on the left, and you look at the fairly symmetrical pattern of their breathing. This is a patient who's had an Ivor Lewis esophagectomy. They breathe with around 90% of the contribution coming from the chest and less than 10% coming from the abdomen, which is fascinating when you really think about when we really focus upon the thoracotomy in terms of what we're doing in terms of surgery. And this is just basically where we're up to with it all, which is that basically now what we're looking at is we're trying to break down the segments of the chest wall and looking at the relative contribution of each of these segments, with the idea being is that there may be a potential muscle group that we can target in the future for focused physiotherapy in these patients before surgery, which will then last into the post-operative setting. And as I said, you can break down the segments of the chest wall to look at each individual motion of the chest wall during a respiratory cycle of a patient, during forced exercise and during a resting breathing as well. And then finally, one of the things that I think is fascinating in the prehabilitation setting is the utilization of wearables. So this is a study that we're undertaking looking at Google location history of a patient. So this is an individual patient. Basically, this has mapped the patient's data for the preceding months before they had their diagnosis of cancer, after they had their diagnosis of cancer, during their neoadjuvant therapy, and then afterwards into the rehabilitation setting. And I think it's fascinating because if you look at it just from the patient's phone data, using an algorithm which we've developed to look at whether or not they're in a vehicle, on a bicycle, or by foot, you can see that there's dramatic changes around the time that the patient had their diagnosis and during the neoadjuvant therapy, along with during their surgery. And then there's a period of time when they actually take time to recover, but they never quite reach the setting that was seen before surgery. And that's really the goal here, is to try to get them from here to here. And I'd just like to touch on the last point, which is that I think when we think about prehabilitation or rehabilitation, we have to really think about what's important to patients. And it's a multi-dimensional approach. Survivorship is a complex concept, and it involves all of these aspects, and physical fitness is just one of them. And therefore, we really can't neglect the psychology of the nutrition of these patients, which can be potentially taught in the prehabilitation setting, but can last for many years into the survivorship of these patients after surgery. So the take-home messages is that the core components, in my opinion, of a prehabilitation program are physiotherapy, nutrition, and psychology. They are not mutually exclusive, and they're independent in every fashion. I'd like to thank all of the international and UK collaborators who I've worked with on much of this research for many years. And I'd like to thank you for your time, and I'll take any questions.
Thank you, Shiraz. That was a really good whistle-stop tour about the science behind prehab. I think what I would do is that I know that Andy is touching upon some of these points as well. So shall we just go to Mr. Andrew Davis next, and then take the questions afterwards, and then go to Claire, so then go to Susan at the end, if that is okay.
Sure.
I have now the other thing I wanted to say is that just so you know that Mohammed may have to leave. He was on call, and he may be called in. So maybe we should just go ahead with Andrew next, followed by Susan. Over to you, Andrew.
Great, thank you, Dip. Can you see that opening slide?
Yes, we can.
Okay, great. Well, as Shiraz said, I'd also like to say thank you very much to the organisers for the opportunity to speak. And my subject touches on Shiraz's in many respects, insofar as we're both trying to sort of give the audience an idea of the data behind and the evidence for prehabilitation. So today, of all places, it's strange to believe that of the two pretty old institutions that feature in the diagram at the bottom of my opening slide, one is an international laughingstock with shambolic levels of management, financial disrepute, and the other one is an NHS hospital. And that's sort of staggering to think, really, isn't it? But it's been an interesting day in Westminster and on the Thames, as they say. I have no disclosures. My only one is that I've caught the half-term lurgy off the children, which so if I start coughing and my voice goes, I've got a glass of red wine on my left-hand side, which I may need to resort to. Other than that, I have no financial disclosures. In terms of the evidence for exercise in cancer, you can go back quite a long time. JCO, more than 10 years ago, fitter patients with breast cancer had better survival, even with metastatic disease, and actually plenty of evidence for improving the tolerance of treatment, both surgery and chemotherapy with patients undergoing exercise programs. And although we've tended to focus on ERAS and enhanced recovery, relatively little has been done on preparing people prior to surgery, which, given that everybody knows the analogy of running a marathon, is somewhat surprising. But the data has been out there for quite some time. If you look at the fitness of patients being given neoadjuvant chemotherapy, on average, it drops somewhere between 15 to 20%, which, given that surgery causes a similar drop in a patient's fitness, could leave a given individual in their 70s 40% less fit than they were at the beginning or at their diagnosis. These are the active clinical OG prehabilitation trials, and there are a few, such as WestFit and SafeFit, that are not OG cancer specific, but would also recruit patients with upper GI cancers, and many are from North America and Europe. In terms of UK studies, many colleagues have done some outstanding work, and these are the studies that have been either published or are in progress in terms of the UK experience. But I think we have to be brutally honest, and we have to accept that the level of data and the quality of the data is limited to often single center studies with small patient numbers. And essentially that reflects the environment, which is that people are trying to work out how to deliver these interventions within a financially constrained environment, and essentially trying to prove principle. And the meta-analysis that I refer to at the bottom there is the one that Shiraz highlighted earlier on. So these are the sorts of studies that we're going to be referring to. and these are 6 or 7 of the main, predominantly UK-based studies looking at prehabilitation that I referred to earlier on. And I would say it's actually fairly rare. I know that Suzanne is doing the third talk. It's relatively rare in any kind of OG forum for the UK to be anywhere near parity with the Dutch. We generally go to conferences and just listen to the Dutch groups presenting incredible trials that have been devised. And actually, I would argue almost prehabilitation may be one of those ones where the UK is at least sort of holding its own. So when we go forward and look at which outcomes exercise may in theory help, starting at 12 o'clock, you've got some obvious ones. So post-operative complications, fitness, sleep, body composition, the overall inflammatory response, quality of life, chemotherapy response, chemo tolerance, and length of stay. And so just simply from those 7 references that I put up earlier on, these are the statistically significant benefits that have been shown in those trials. And so whilst we may look at those individual studies, and there are clearly methodological challenges and patient number issues, when you take a step back and when you look overall at an intervention that is inherently logical, and when you start to put together the results from these 6 or 7 and other international studies, you do start to get a picture that that there is an overall benefit. And then the question for us as a community is what do we do with that, and what do we need to do with that to prove that principle further. So exercise may, in theory, improve all of these outcome measures, and the one glaring outcome that's there at 3 o'clock is survival, and at this current moment in time, there is relatively little evidence of that benefit, but that may well change in the near future. But we've still got lots of questions. So what is the type of exercise? So this is the current state of the nation coming out of COVID lockdowns. We've all been familiar with going to the gym and reading a magazine whilst on the exercise bike, and we think we're exercising, but actually in truth, are we? But in reality, we're not going to ask our patients to perform miraculous feats of athleticism, as shown in these three pictures. So where do we strike that balance between something that's realistic for our patient group and something that was actually going to give them some benefit? So how do we deliver and monitor this improvement? Plenty of questions still unanswered. Supervised or unsupervised? Is it in hospital, in the gym, or is it at home? Is it delivered by a physio, an exercise physiologist, a personal trainer, or a nurse specialist? How do we measure response to exercise? Do we use CPEX testing, which, albeit is considered the gold standard, is time consuming and expensive? Do we use surrogate measures, for example, 6-minute walk tests, hand grip, sit to stand, or respiratory muscle function? And I think this is really important. Do we now consider that prehabilitation needs to be done within a trial, or is it now just good practice? I'd say from a personal perspective, I'd be very interested to hear what the other members of the panel and the speakers think. But when you try to recruit a patient into prehabilitation, they can completely agree with the principles, and then the moment that you mention ethics and consent and actually putting somebody into a trial, there's this barrier that goes up. So do we now consider that to do prehabilitation, do we think that these people all need to be entered within a trial, or do we think it's just good practice? In the UK, I'm sorry, this is sort of unashamedly just a UK slide, but what's our national strategy for prehabilitation? One might argue that you need to understand what is the current status of prehabilitation. You need to understand what the current data is, both in terms of what we do know, but probably more importantly, what we don't. There are possibly opportunities to merge data from studies that we've already published. And in theory, those three aspects could go into a multidisciplinary pan-UK working group, which will deliver to Augis within the next 12 months a document on the current status and future directions of prehabilitation in major OG cancer surgery. I think we have to accept that there may well be more questions than answers that would be part of that document. But then importantly, where does that move us forward in terms of prospective collaborative opportunities? I would say that from a perspective of sitting on a number of subcommittees that are looking at this space, what we probably don't need as a community is further studies of 40, 50 and 60 patients doing proof of principle. Yeah, there actually needs to be some overarching direction. But all of these things are achievable and are in progress. I'd like to thank Rob Walker, who's our senior fellow at St Thomas's, who's currently putting together this data on a systematic review of exercise prehabilitation during chemotherapy, a review of over 800 manuscripts across numerous tumor groups, really exploring this idea of neoadjuvant therapy and people having prehabilitation programs. Essentially 18 trials, 11 of which are randomized, a mixture of OG, colorectal, breast and head and neck, a total of 1,400 patients with statistically significant improved levels of fitness, body composition, inflammatory markers, chemotherapy response, and HRQL. So we don't have a single large definitive trial, but what we're all trying to do is piece together aspects of the evidence to try and give you an overall picture. This is a unit questionnaire that's now been administered to about 60% of UK centres. And I'll just give you a little insight into where we are currently as a UK community. Do you currently offer a prehabilitation programme? So almost 3/4. And many of those centres have been offering that programme for 5 years or more. What funding is provided? Well, about 50% of the time that's funded by the trust, but probably more importantly, the other 50% is on either non-renewing funding sources or from research study. What are the main barriers to maintaining prehabilitation? Well, unsurprisingly, that's going to be a lack of funding and a lack of manpower. Specifically, I think here we're talking about physiotherapy type resources as well as psychology. And who is principally responsible for delivering the service? Well, 60% of the time that's NHS physiotherapists, but a significant contribution from other healthcare workers, both within and outside the healthcare system. Reassuringly, well, 90% of these programs are being delivered from diagnosis. I think that's now fairly well acknowledged, is that this is a process that needs to start at the very beginning, and to ignore that neoadjuvant chemotherapy, chemoradiotherapy stage would be a mistake. And in terms of where the program is delivered, about 50% of the time that's in hospital, and 50% of the time in other facilities, either NHS or non-NHS. For the most part, the training programs involve aerobic and often a combination of that with resistance training, as you might expect. And about 50% of the time we're using CPEX testing, and the other 50% we're using other surrogate markers of baseline fitness. This is also important then, once you've initiated your intervention, how are you monitoring the changes in fitness? And again, 40% of the time we're using CPEX, and the remainder we're using other surrogates. So there seems to be quite a lot of uncertainty as to what the role of formal cardiopulmonary exercise testing is in these patients. I think this is a really interesting chart, which is when we ask in theory to those participants, where do they believe a prehabilitation program should be delivered? As a community, we've clearly not got a clue. We don't know. Some people think in hospitals, some people very strongly believe out of hospitals, some people think that that should be virtual. Lockdowns, COVID has changed perspectives on many of these things, but this, at the very least, I think what we need to take from this is that there is a great deal of uncertainty as to how these programs could and should be delivered. But in terms of some things that we think we are a little bit more certain of, NHS physiotherapist there on the left-hand side is widely considered to be a very important component of these programs, and dietitians. 93% of respondents thought that nutritional or dietetic input was very important. Strongly agree, and 95% either agreed or strongly agreed that psychological input is an important component. In terms of psychological input, 50% believe that that should be routine, and 50% believe that it should be on a selective basis. Predominantly, that's resource driven. I think this is an interesting graph as well, which is that 60% of us don't have routine access to a psychologist for OG cancer patients, which, given what Shiraz was talking about in his first talk, I think is an interesting insight into where we are at the moment. In answer to the question of whether we now considered this should be standard of care, there was broad agreement that prehabilitation should now be standard practice, but not such strong agreement that this should be a performance indicator in a national audit. Which is interesting because in some ways being a performance indicator is one of the ways that trusts can actually access their managers to force change. So I suppose, as with every change, a degree of trepidation about wanting to be judged by the delivery of a service. And I'm sorry, this is a little bit busy, but I'm very nearly finished. What outcomes do you believe that prehabilitation may improve? And so everything down that left-hand column that's highlighted in red gets extremely high levels of confidence from the participants. So we really believe, obviously, that fitness, activity, smoking cessation, complications, length of stay, getting to adjuvant chemotherapy, and quality of life, we seem to strongly believe that those things are all improved. But I would give you a perspective from having run a trial in prehabilitation that many of these things, like CPEX testing, blood tests for inflammatory markers, longitudinal follow-up for HRQL, this is really expensive, it's time consuming. And there may be an argument that we reach a point as a community where we accept that these are actually research questions. They live in the domain of a research study, but they are not mandatory for those people just doing this as a day-to-day clinical practice. And maybe that's something that comes up later on in the discussion. So in summary, is prehab beneficial? I think there's quite a lot of evidence now that it is, but we still aren't quite sure of what the intervention is, where it should be, and who should do it. I think we can be confident that it should be from diagnosis throughout chemotherapy, throughout the run-up to surgery. We're still not quite sure how we should be measuring either baseline or response to our intervention, but we are pretty convinced that all three of those components, as Shiraz said, are important to the process. Do we still need trials, or do we consider this standard practice? I think is still up there to be decided as a community. Just going to leave you with this, which is unpublished, but in the process of being written up. These are survival curves, so overall and disease-free survival for patients who participated in the PREEMPT study based in London. So the red and the blue lines are the interventional and control group, but I don't really want you to look at those. The green curve are the patients who were offered participation in the exercise trial and declined for a variety of reasons, but importantly, they are all patients who still came to surgery. So they were not withdrawn because they progressed or their cancer changed. They still ended up having an operation with statistically significantly worse survival outcomes. And I think really acknowledging all of the issues with numbers and power, which is inherent in many of these studies. But I think it does highlight one important thing, which is there are a group of people that are currently inaccessible to prehabilitation programs, and arguably they are the most important. They are the ones that cannot be forgotten. They cannot be left behind. We don't need to be training people who are already running marathons before their esophagectomy. We need to access the people that currently are resistant to doing it for many reasons. And I think that's important that that we remember that. And as Shiraz said, very happy either as part of the chat later on or by email to answer any questions you may have. Thanks for your time.
Thank you, Andy. So I think we'll have a few questions now. The chat box is empty. I just looked at it and I think nobody has written anything. So maybe I'll go to Claire now. Claire, as a reader of evidence and research, tell me, where do you stand now and what is your view? Is this good science? Is this bad science? Do we need more science, or is it just part of normal activity? We saw what is happening in the survey that Andy produced, what's happening across the country, and I'm sure that some of the OG's position statement will be based on that and preemptile. But at the moment, what do you think where the science stands? Thank you. Over to you.
I think the chat is disabled, which is possibly why there's no questions in it. So I'm not sure if anybody who has host can maybe reactivate that, because I see there's lots of people in the audience who have experience in prehab. See a number of people from our unit who provide our prehab service are logged in. I'm sure they have questions or comments that they'd like to make. So I'm a believer in prehab, partly on the evidence, but actually partly just on experience from seeing people going through prehab. I think it's really beneficial for patients. It takes people who are seldom exercisers and gives them something to do. It gives them currently what we have a number of studies ongoing, and we're looking at what actually is beneficial in terms of exercise. Emily, who's in the audience here, is doing a pre-HIT study. So she's looking at a randomized controlled trial of people having our standard prehab service, which is an individualized exercise service, versus doing high intensity training as part of their prehab service, and doing it for a very short focused period of time before surgery and looking at their outcomes. So I think we do need more data on what is effective for people, how individualized the exercise goals need to be for different people. And I thought some of the information that Andrew and Shiraz shared really shows us where we're going. Looking at that group of people who decline exercise is a massive unmet need, I think, and something that's really interesting. I had a question then for Andrew and Shiraz, based on your talks, a little bit about psychology input, if that's okay. So do you think we definitely need psychologists providing the psychological input, or how much do you think the multidisciplinary team might provide kind of psychological support for our patients when they're going through prehab? They have a lot of contact with our physios, with our dietitians, with the surgeons, with the nurses. Do you want to take it first, maybe, Shiraz?
Yeah, so absolutely. So I think there's definitely Andrew's point, survey questionnaire about 60% of centers having no access to a psychologist I found fascinating, actually, in all honesty. I think, in all honesty, what we need to do is we need to identify the patients where they really need the help. And I think that can be done either, as you rightly say, by a trained physiotherapist who has experience with this, or a member of the team. But it's really trying to identify those patients that will maximally benefit from psychological input. There are lots of screening questionnaires that are available that may identify it as well, may help you identify it. But I think one of the things that I think is useful is for a patient to just touch base with a psychologist just at the start of their journey, and then know where they sit. And then in the longer term, you can see whether or not that patient needs regular touch points, or whether or not they don't need it. And it will be very individual to the patient. And I think that's the thing that we need to really understand, is that no one patient is the same psychologically. They're all very different. And therefore, trying to prescribe it like a medication doesn't work, in all honesty. That's what my dad used to say to me all the time. But yeah, but absolutely. So I've kind of grown to agree with him over the years. But yeah, about that. Anyway,
if I may interject, I should not as a moderator, but I recently asked this question to the psychologist in Northeast London, because I lead the alliance in this area, and she said there's no hope in hell that you're going to get it for every patient. So what she suggested, which is a very, I thought it was a very pragmatic way of going about it, is that the psychologists train the CNSs, give them, they all trained, but refresher and stuff like that, which has often stopped during COVID. And then that allows the CNSs to identify those at the maximal need. So again, in cash-strapped NHS, that may not be a bad idea, that we identify the ones that who need it most. But of course, when talking about what actually happens, not what should happen, perhaps. I've got two questions in the chat box, and that's from David Liu. And David, thank you very much, because you popularized this meeting to the wider world by retweeting some of the initial tweets from Tugs. And David has made a comment. I think he's complimenting Andrew. I don't know whether he's complimenting Andrew or the red one or whichever, but he says, love those photos, Andrew. So how do you ensure compliance? Okay. So he's got three questions then. One is, and I want a quick fire question, quick fire answer, and I will go to Krishnamurthy on this actually. Krishna, what do you think is the minimal duration of prehab that is effective? I want no story. I want a quick fire answer, because these are sort of guidance that minions like us need. What do you think is the minimal duration of prehab that is effective?
I'll give you a politician's answer. It depends on what outcome you're looking for. If you're looking for physical fitness, then even 2 weeks is enough. If you're looking for psychological well-being, again, 2 weeks is enough.
I think that's not a
politician. That's what they've shown. That's what they've shown in colorectal surgery.
Mm-hmm. Okay, the second question, which is, I think, interesting question actually. Sorry, we had another question in the audience actually. So the second question is, what do you do for those who don't need, this is a very provocative tongue-in-cheek question, David, thank you very much for this. What do you do to those who do not need neoadjuvant treatment? Do you delay surgery for 12 weeks for prehab? I think Krishna has answered that question, but I will probably go to Ewan here as a jobbing high-volume surgeon. Ian, what would you do? Do you delay surgery for 12 weeks for prehab? This is like Dragon's Den. And provide fast-track prehab pathway, and for how long?
Yeah, that's an interesting question. I mean, clearly, if they're borderline fit for surgery, there is benefit in delaying surgery, but it's a risk balance of waiting for the cancer to progress. But a borderline patient who we think we could make adequate changes in their fitness, psychology, smoking cessation, all the stuff we've discussed, I think you can delay surgery for 6 weeks and get them on a program. And I think that would be beneficial. I think if they're flying, doing marathons, very fit, I wouldn't bother. I'd just go straight for the next date for an operation. But there's certainly those patients who'll benefit for a prehab program if you're not going to do neoadjuvant. But neoadjuvant treatment knocks our patients around a bit. So I mean, the best programs interlace these treatments with the chemo units and the sort of oncologists as well. And you want a Class A service. We don't have it in Birmingham. We're trying to develop it too, but that's what we're all aiming for, really. And we like Andrew said, we've had devastating levels of poor fitness, smoking in our patients in Birmingham with the COVID. Has really wrecked our patients. So yeah, great to be involved in this talk.
So we still need to answer the second bit of the question. How long will you delay surgery in a pragmatic manner in such a patient? How long do you do it? Because your physiotherapists need to know, and your juniors need to know, your team needs to know how long, on an average, perhaps on a ballpark figure. Give me a ballpark figure. Do you agree with Krishna that it should be 2 weeks, around 2 weeks?
I personally think that's too short. I think I'd go for a month, 6 weeks, maybe, okay, maximum with the cancer, Yeah.
So these are the questions we need answered to. Thank you, Ewan. And I'm now going to go to the question that Emily Smith has asked. And Emily, thank you very much for asking questions. Keep the questions coming. We will go to the next speaker very soon. But however, one of the things that I noticed when both Andrew and Shiraz were talking is that the evaluation phase. What is the instrument that you use to measure whether the prehabilitation is effective or not? And there is a whole lot of things, and ultimately survivorship and all that sort of thing that we talked about. pulmonary complications. She says that it'll be reduced by it, and I know that there is some data on that, and I know that Krishna has published on reduction of complications. Andrew showed some of the data. The question for Emily is actually very specific. It's actually about CPET, which I think she means CPEX. Now she talks about two questions. Number one, what is the feasibility and acceptability of CPET testing for preoperative patients? Do you do it in all? Because if you provide prehab to all, will you do that routinely for measurement? And is it helpful? So it's slightly around the topic rather than in the topic. Is it a helpful tool to assess preoperative fitness, or is the whole experience too much? Because this is a very good clinician's question, that we are diagnosing them, we are staging them, we are then battering them with physiotherapy, we are sending them to CPET, and then should we repeat it afterwards, and how that bears on decision making. So I want a view from our chairs, and I'll now go back to Ewan again, and then I'll go back as I did. Ewan, would you, for patients who are fit, reasonably fit, and they're going to undergo prehabilitation anyway, would you do CPET before? And if you do, will you do CPET afterwards? Or will you just clinically assess them?
Yeah, no, it's a good question. We don't have easy access to CPEX testing in Birmingham. We have explored it. Our routine pre-COVID was shuttle walk testing, and that served us very well. Sadly, we don't have it currently, and we were discussing getting CPEX testing back. Previously, we only used it in patients who we thought were very borderline. And the problem there is sometimes they come back with a surprising result, and then you don't know what to do really. But it isn't the be end and end all. We've had patients that can't manage the bike. They've got arthritis, so it's not a fantastic test. And if you look at the data on CPEX, it's a bit uncertain about what cutoffs you use, whether you actually operate on them anyway. So in Birmingham, we prefer a shuttle walk test, and that as I said, that's been our go-to fitness test. We haven't quite had the capacity to do a prehab program and then repeat it, but that was in our plans, and that is our plans when we get back with our prehab program.
Thank you so much. And I think that's a very good answer. And I think there's a question of funding as well as to how we're going to get it, whether we should do it in research study. And I think perhaps you should give. We have been using CPET tests only for potentially unfit patients. And like you and I have been caught where you get a surprise answer and you don't know what to do with, and you go back to this anesthetist to sort of appeal to make the final decision. Claire, what do you feel? Do you think that let me ask this question slightly differently. Do you think that the CPET is a good test to measure improvement in or presumed improvement in fitness following prehab? Because we are only looking at their performance and exercise tolerance and stuff like that, and their cardiopulmonary aspect of it. It doesn't say anything about psychology and other things, and nutrition. Perhaps does a bit of nutrition. What do you think?
Yeah, I think CPETs aren't that useful because in borderline patients, they're often borderline results, so they don't actually really help with diagnostic decision making. And that's, I think, an experience thing that some people are, with more experience are good at picking out patients who are fit or unfit. But that's, I don't know how you teach that or how you objectify that. I'm not sure it's the best test. I think it's putting too much demand on patients to actually be able to help with your decision making. It doesn't measure the same thing as getting them through the surgery.
Yeah, I think that's what Emily is trying to say.
There are other tests that are better or could be better.
And thank you for that, Claire. And actually, Emily is expressing similar sentiment in her question there. I'm going to go to Krishna. This is a Dragon's Den kind of question again to you, because you are a super expert on this. And my question is this: have you done CPET before and after prehab? And if so, what have you found?
So when we set up the program, we realized CPEX is not cost effective, and especially not scalable. So we, just like Ewan said, we went for sub-maximal exercise testing. And we use it mainly as a screening test to personalize the exercise programs to each individual. And in our center, we've never really clinically applied CPEX to our clinical decision-making. So yeah, I personally, and I haven't found CPEX to be useful either clinically or within a prehab setting.
Fantastic. Now we are going to go to Susan. I know that you're overrunning a little bit, but we saved the best for the last. We are not under pressure in terms of time. I know that the participants will often stay, and we have exactly the same number. In fact, we have gone up during this time. So Susan, you've got a bigger audience than we started with. Without much further ado, we are very keen to learn. I don't know whether you heard what Andy said, that what Netherlands thinks today, we will think that tomorrow, and I certainly am particularly grateful to Dutch surgeons, and one of the Dutch surgeons from Portsmouth is my proctor in robotics, and he didn't mind having an old student like me, and was extremely kind and partial to me. And over to you. We are really keen and to hear from you as to what you got to say about this. Welcome.
Thank you so much for the kind introduction, and I'm very honored to speak here today. Let's see if you can see my screen.
Yes, we can.
Yes, so I will talk about a clinical case for a prehabilitation improved outcome, and also some future perspectives of prehabilitation, as well also a little bit discussed by the previous speakers already. So patients in our hospital get referred to GIOCA, which is the Gastrointestinal Oncologic Center in Amsterdam, which is part of our hospital. And this is a patient-centered process with one-day diagnostics, the MDT, and the patient that meets all specialists that will treat him or her. And this is a little bit what it looks like. So they get referred and then triaged by the oncology nurse and the radiologist to see if additional imaging is needed. Then they're screened by the surgeon or the gastroenterologist, also for fitness, and also if necessary by a physiotherapist and a dietitian. Then there's the MDT at noon, and then later the patient gets the results and the treatment plan. And then also, when patients get neoadjuvant treatment and surgery, we have group counseling in between. And here the surgeons, the nurse, physiotherapist, dietitian, a psychologist give all a short presentation to the patients. And what they can expect in the ward, and also during the treatment and during the post-operative period. And they also meet all these experts and other patients. So our case today is a male patient, quite young, 53 years old, who had a history of alcohol and tobacco abuse. He has a very low BMI of 15.5 and lost a lot of weight. And he has, because of severe dysphagia, and his WHO score was only 2. But however, he was very motivated, and he was very willing to quit with his bad habits. And this is what the endoscopy looked like. So he had a tumor at 25 to 32 centimeters. Sorry. Scan. And the biopsy showed a squamous cell carcinoma. And on the PET-CT scan, you can see that it's a proximal to mid tumor with quite a close relationship to the airway, and also a high paratracheal lymph node metastasis on the right side. There you saw it. And we did a pulmonary function, as we do in all patients, especially the expiration phase was decreased somewhat, but not actually too bad. Like the forced expiratory volume in 1 second was 72% of predicted. And there was officially no expiratory obstruction. His VC max, however, was decreased. And also we had him tested with a physiotherapist. And he did quite bad here because he could not finish the exercise test because of his poor physical health. And also his other parameters were much lower than the norm. So his inspiratory and expiratory maximum pressure, his 2-minute exercise walking test, 30 seconds chair stand test, and the hand grip strength were all very much decreased. So in our MDT, we had a discussion. He's a young guy. He has a stricturing tumor on a terrible location. There's, of course, 2 options: definite chemoradiotherapy or surgery with neoadjuvant chemoradiotherapy. And we had a lot of discussion about this, but considering this stenosis and his young age, we thought that neoadjuvant treatment and esophageectomy would probably be the best option for him if we could prehabilitate this patient during and after neoadjuvant treatment with a personalized program. But how big is this problem in these patients in our population? We investigated this in 360 patients, and we looked at sarcopenia, so the decreased muscle mass, decreased muscle mass. And we saw that especially in squamous cell cancer, this was 72%, so very high, but also in adenocarcinoma, more than half of patients was sarcopenic. The incidence also increased during the neoadjuvant therapy, although the BMI and the fat percentage decreased, and also these patients had exercise, so the muscle strength showed an increase. You don't have to read this whole table. I just want to show that patients who had sarcopenia had a higher fat percentage than patients who didn't. And they also had a lower muscle strength. And there were also quite a high rate of sarcopenic obesity patients. And when we looked at complications, which is of course one of the most important parameters if we look at those kind of data, we saw that body composition and muscle strength were both not associated with the incidence and the severity of complications. And also when we looked at survival, there was no difference in overall survival between patients with sarcopenia and no sarcopenia. And also the change in body composition during the neoadjuvant therapy was not associated with overall survival. There was, however, a lower survival if there was a decline in fat percentage and skeletal muscle index and an increase in BMI. And if we did a multivariable analysis together with the traditional clinical variables, we found that a lower number of stands during the 30 seconds chair stand test prior to chemoradiotherapy and a higher rate of visceral adipose tissue after chemoradiotherapy were associated with worse survival. So on the long term, we did observe some differences. Next, we looked in this prospective core study of 19 patients if the functional status was associated with postoperative outcomes on the short term. And we measured this one day before the surgery. And we did not find that any of the indicators of a preoperative functional status was associated with postoperative complications. As you can also see here in multivariable analysis, no differences. And the next step was to look at it over a longer period of time. So we measured this 3 months and 1 day prior to surgery, and also 1 week and 3 months post-surgery in 155 patients, and we measured the functional status. A little bit more than half of the patients had a complication, and we found that the functional status returned to baseline at 3 months post-surgery, except for the hand grip strength and fatigue. But there were no differences in the course of the functional status between patients with and without postoperative complications. So not all patients benefit from high functional status to prevent postoperative complications. And we concluded that you need to evaluate all your patients individually, and the timing and tailoring of physiotherapy treatment should be based on the individual needs. But it could also be that we're probably not looking at all the right data. For example, in this study, also from the Netherlands, evaluated 78 patients, not a very high number, but they found that body composition variables from the preoperative CT scan, which we had in our sarcopenia study, were only moderately associated with the cardiopulmonary exercise-derived aerobic fitness. And also from this same group, a review, which was quite interesting, they found that, we also talked about it today a lot, that the cardiopulmonary exercise testing is able to predict at first postoperative outcomes, but it's time consuming and requires expert assessment, and that the incremental shuttle walk test and the 6-minute walking test are feasible alternatives. However, muscle strength and function tests have limited value in risk prediction. So it's all about this aerobic fitness. And there's an indication for especially high intensity interval training, because you only have a limited period of time. If there's an oxygen uptake less than 11 milliliters per kilogram per minute at the ventilatory aerobic threshold, and or less than 18 at the peak exercise. So what do we do in Amsterdam since all these studies? We assess the patient individually. So the Dutch norm, the Dutch guideline on how much you should move is 150 minutes per week, moderately intensive, and twice per week, exercise that strengthen your muscles and your bones. Then you get a score of 1 or 0. The second question is, how fit is the patient at this time? Can the patient walk 100 stairs without stopping? And how was this half year ago? And then you get some points. And if you score bad, you are referred to a physiotherapist. We have the same for a dietitian. I think you all know the SNAC score, and we have an individualized protocol to follow depending on the score. And also for the psychologist, we have this distress thermometer and also some questions if a patient needs or wants to be referred for this. And additionally, we assess frailty to refer, if necessary, patients to a geriatrician, and also comorbidities like anemia and diabetes and intoxications. There's also a study going on that is called Better Prepared. It's also together with other universities that has an app with also the 3 main parameters: move, feeding, and intoxications. So our case was referred to a dietitian and got tube feeding via the nasal-duodenal tube, also referred to the physiotherapist, and he exercised at home daily and also went to clinic twice per week with supervised training. He stopped smoking and alcohol intake, and also had pulmonologist consultation. And all this was strictly coordinated by our nurse specialist. Then he was treated with chemoradiotherapy in the meantime for 4.5 weeks. And he came back a month after this treatment, and it was really much improved. And he quit smoking and drinking. He gained 5 kilograms of weight and really stuck to the exercise plan. And this was also shown in the evaluation by the physiotherapist. So his VO2 max improved, his exercise capacity, actually all values improved to the almost the normal values, and some even better. And this was the scan, the restaging PET-CT scan, which did not show any metastasis, and also some response, although we don't strictly use it for that. And then we did a minimally invasive transthoracic esophagectomy with cervical anastomosis. He did develop a pneumonia, but it was quite mildly. Was treated with antibiotics and no respiratory insufficiency, and he had a good pathologic outcome. And hopefully he will stay disease-free. And then just a few slides on the future of prehabilitation, because there's a lot of technical developments going on that's also interesting for us surgeons, such as patient engagement apps. These e-coaches, they encourage patient engagement. They can integrate the digital data in personalized and tailored way of care. They can actually induce a change in behavior and provide an individualized feedback loop. There's also in these wearables convergence between the consumer wearables and the medical device markets, where the leaders in the field of wearables, such as Apple, are moving towards personal health devices, and the medical device companies, they develop devices that can be used outside the hospital, but still give feedback of medical data into the patient treatment workflow. And they can also provide, I think Shiraz also showed this, the multi-parameter longitudinal data and aid in the development of algorithms. And there's many out there on the market, such as this one from Sensely that also has chronic condition monitoring, symptom checker and triage. But also for your mental health, you have a lot of these apps that have an intense training program. The first Fitbit was already launched in 2009. These watches can control your sleep quality, your daytime recovery, your stress level, movement, mental well-being, and also even your levels of executive brain performance. And you have many different brands out there, and even they can spot the flu if they detect changes in your heart rate or in your saturation. And it's not only watches, there's many more of those kind of things like stickers and sensors and camera clips that all can monitor you, and even rings that can provide all these data for you. Also your voice. In your voice, you can also detect different kind of diseases. And it can all be connected to your smartphone. It can be used in research, but also in clinical practice. Also in the University of Queensland, the cough analytics have been described. You can only not only detect corona, but also other diagnoses. Your iPhone is much better than our stethoscope as doctors. The e-nose, I think Shiraz and Judge Hanna have done important work with the breath analysis, of course. And also, I don't know if this video is working, but you have stickers that, no, it's not working. Stickers that can measure your pH in your sweat and all kinds of electrolytes and can really follow you and give you feedback on your health. Oh, there's it going. I just show a short bit of this. So these are actually small laboratories that we can just stick on our skin. And this is very interesting for the future. And also even our toilets can analyze our stools and urine and provide feedback on our health or small drops of blood. And also the insurance companies are very interested in this preventive monitoring because they give like rewards if you exercise. You can get points and small rewards. So the future of prehabilitations was already also shortly discussed by the previous speakers, but it should focus on patients with a low period of aerobic fitness based on evidence-based cutoff values. It should aim for partly supervised high-intensity prehabilitation programs. It should be executed in the living context of these high-risk patients to lower the hurdle to preoperatively optimize their physical status and to demonstrate the potential of prehabilitation to improve patient-related and treatment-related outcomes. So first evaluate, then personalize and monitor the progress, all using these new high-tech solutions in collaboration with tech universities and your multidisciplinary team. So even the presented patient with structural squamous cell carcinoma, prehabilitation was possible. It requires strict coordination and follow-up. In our data, not all patients seem to benefit, but we have to be sure to measure the correct values, such as the cardiopulmonary exercise testing or some alternatives. And future studies should be patient-tailored and involve high-tech solutions. Thank you very much for your attention.
Thank you, Susan. That was wonderful. It really is. I just came back from an international conference where there was a lecture, and I subsequently talked to Dr. Gums from Paris and from France, from Saint-Germain, and he was talking about. He comes from Lionel Messi's city, Saint-Germain, and he was talking about how artificial intelligence is going to affect all this. And I know that Krishna has a lot of experience in using technology and developing technology on this side in the UK. And there was a lot about avatars and nanobots and everything else. And I think the world is already changing. The future is already here, and we are probably trying to do a catch up. May I just ask the panel now, the chairs? May I just ask Claire and Ewan and Krishna to, if you have any questions to start with, to Susan, please.
I was just interested in the model of providing prehab in the community that happens in, I think, in the Netherlands, where people don't necessarily have to be tethered to the hospital and have to come in and out of the hospital for exercise classes. I think there's a model where people can get it nearer to their home in local community centres, and I wondered if you were able to tell us a little bit about what that looks like in real life.
Thank you for your question, Claire. And that's correct. So if possible, we refer patients to their own physiotherapist, which is close to their home, and this is usually possible. And there's also usually these groups of physiotherapists that have a specialization for oncological patients. So and the GP system is very good in the Netherlands. So usually the general practitioner, we contact them, and they know exactly which physiotherapists are more specialized in these kind of patients. So this is a system which works quite well. Sometimes also because most of our patients come from quite far away, so they have to, if they would need to come to our hospital, they would have to travel quite a bit. Of course, if they live close to the Amsterdam, they can come also in our hospital to the Department of Physiotherapy. But most convenient is just a practice close to their house, and this is actually always possible.
Ewan, do you have any questions?
Yeah, no, that's a really insightful talk, Susanna. I really enjoyed it. It's amazing what you can achieve to get a patient like that to surgery, really. Just expanding on the sort of things that are available in the community. That in Birmingham, we've got a patient support group that pre-COVID, they were doing walks and things like that. And Macmillan as well, they're a charity in the UK, and they do some prehab as well. And we tried to connect with various places that are doing, sort of prehab-like projects in the community. The main one is sort of cardiac rehab after sort of heart attacks and things. That's a big thing in the UK, but we never successfully managed to achieve that. And it seems like you've got a much better system in the Netherlands to try and achieve that and get your patients fit, because the key is getting something closer to their home that they're actually going to do and participate in. And it looks like just congratulations on the system you've got. Really profoundly jealous.
Thank you.
So
but I think you're not doing very bad yourself, actually, because I think also the work you've done on the research in the UK on prehabilitation, that's really impressive, I think. So I think that can also serve as an example for us.
Thank you, that's very kind. May I just ask a naughty question now, because it's my job to ask naughty questions. So Susan, if this patient stopped smoking, which they sometimes do, and had responded to neoadjuvant, hence he can eat, do you think that would be enough, or is there anything that is added by this extra bit that he went through, your patient?
Sorry, it was by the last sentence.
I'm saying that if you did not have prehabilitation, this patient, it's a hypothetical and very naughty question. It's a very unfair question as well, but I'm just trying to be devil's advocate here. So let's say this patient had neoadjuvant and started eating and put on weight, and stopped smoking because the CNS is he likes the CNS, and the CNS somehow manages to talk him out of smoking. Would that be enough? Because we do know that some patients really improve very rapidly with neoadjuvant alone.
Thank you for your question. Yeah, I agree. We don't know. We don't know this, of course, but I think this is really an example of an excellent patient, because this patient was so motivated, and I think also if patients are so motivated, and I think Krishna also sees this in his research, that if they're so motivated, they also have a better postoperative course. So they also, after the operation, they get sooner out of bed. They feel also responsible for their own disease and for their own postoperative course. And not all patients have that. So some are really like more passive and like they expect the doctor to fix the problem. This patient was not like that. So I think he was so motivated, and that's why he trained so hard. And so the training helped, I think, but also his motivation. So if he didn't train, I'm not sure if he would not would have had
I think you answered my question. Thank you.
mild positive course.
Yeah. Okay, now I'll go to Krishna, if I may. Krishna, I'm going to give you a slightly. So, of course, you first of all, please comment or ask any questions to Susan that you think is fit. But I have got a personal question to you. We have a huge waiting list in the UK. We also have a large number of preventable deaths following elective surgery. So, although the percentage is small following elective surgery, we are still losing patients after elective surgery. And I would argue that elective surgery death rate should be 0%, because that's what the consumers would like. My question is that is there an opportunity to use this in a slight tangent to optimize all patients in emergency surgery? Because we know that the patients are getting older, less fit, and we put them on the waiting list and we don't do anything for them. And sometimes after a year or two, we suddenly do a pre-admission check and then we operate on them, which is bizarre. And it often doesn't happen in the developing world, actually. I've just come back from a conference in a developing world where there is no waiting list. People, good or bad, they will get an operation straight away and within 2 weeks or so. So may I ask you to anything that you want to comment on what Susan said, and secondly, perhaps respond to what my question.
Over to you. To comment on hi, Suzanne. It's lovely seeing you, and thank you for that fantastic presentation. And it's really amazing what you've achieved, in your center. And you're absolutely right. There's such a great potential for merging technology with the clinical delivery of programs like this, because at the end of the day, these programs do cost money. And, they can vary. We've scoped out how much a prehab program costs. It costs something like 400 to 1,000 pounds per patient for a 12-week program. So it can be quite expensive in today's economic climate. So unless we ensure that it's really working, it's just a waste of money. And that's why, ensuring adherence is really important. And what technology helps us do, it helps us to move very expensive manpower resources to the people who need it the most, while other people can be left alone to do the program by themselves, as long as there's some support available to them. So moving it into the home, using technology, all that is so important to make this, cost effective and scalable. And in terms of your question, Dip, you're absolutely right. All of us, especially in this audience, at least amongst, the chair, we're all, I think, coming to an age where we all prehab. Do you know that data suggests that there's a median 7 operations per human being in the Western world, a median of 7 operations per human being in the Western world. So we are all prehab. And it just fits into the whole preventative strategy, the public health strategy. It's very simple, right? We are now catching people who are in poor health. As in a public health setting, we want to prevent that from happening. So people are already fit when they come for an acute intervention such as surgery.
Thank you so much. I think that's wonderful. I don't have any further questions in the box. I'm sure that we'll keep on talking about it, and the numbers will go up. And I think I personally learned so much, and I really enjoyed company of all the speakers and chairs today. I know that you ran late, and I make no apologies for that. I deliberately let it run late because it was so wonderful. So hopefully we'll not run late next time. And actually, I just want to point out that people stayed. People did not leave in large numbers. So may I just thank the speakers, Shiraz Marka, Andrew Davis, and Susan Gitzberg. May I also thank the chairs, Claire Donahoe, and Krishnamurthy and Ewan Griffiths. Thank you so much. This is a free webinar. We can only thank you. We can't give you anything else. But I think these are sort of events that are widely watched, even if not in real time. So you will have a viewer sitting somewhere in the developing world listening to you, and that is something that the modern technology does to make it scalable, accessible to everybody, break down barriers, and make one global surgical community. Thank you so much. Have a wonderful evening. I'm sure that, Andrew, you have finished that glass of red wine. You can pour yourself another. Oh, well, that must be the second glass. Bye-bye. Bye-bye, everybody.
Thank you. Bye-bye. Thank you.
Bye-bye.
Bye bye.